चलो बहुत सारे डाउट्स हैं और एक जो बहुत ही थोड़ा कठिन आर्टिकल है इसी आर्टिकल में ऐसा ये हो रहा है मतलब ये ऑनलाइन दिख रहा है ना पूछना तो पड़ेगा इस बार भी पहला बाकी ये हमारे पैसे दो Okay. So now, well, this is a good morning, everyone. So we'll be studying of a rough idea of how to go about presenting a journal club, right? So, what is a journal club according to you guys? What is a journal club? It is basically your understanding of a certain article, original article, and then critically appraising it. So whether what are the good things in that article, what are the not so good things, what are the things that you think that the article the authors have not been very keen into. Maybe they have done something which is very loose in nature, not very evidence based. Okay, not according to the appropriate methods. So those are the things you should look for in a journal club. Now, so this is actually a journal club that I presented when I was like 10 to 11-month-old JR. So this is my first journal club. So it will be riddled with many mistakes, but pardon that I have not corrected it because I wanted to show you however I have presented. Okay. So now, yeah. So this was my journal club when I had an SR for moderator and my chairperson was an assistant professor. Now the journal that from which it was taken was this Journal of Psychiatry and Neuroscience. As you guys also do it, it's basically you have to mention some of the details of the journal, who are the editors, which medical association does the journal belong to, what is the publishing frequency of that journal, okay, and what is the impact factor. So do you guys know what is the impact factor of a journal? Yeah, okay. So you must know this. So the impact factor is basically in the last 2 years, the number of citations that the journal has got divided by the number of published articles in that, citable items in that. So in the last 2 years, okay. So this is an excellent impact factor of 5.8, which means that almost if the journal has published around 5 articles in 2 years, then it has got a citation of around 22, 23, 24 for that. Okay. So it's a very good impact factor. You know what is the impact factor of Indian Journal of Psychiatry? It's 0.7 to 0.8. Okay, so the citations are much less than the actual number of articles. Okay, now this is the article. It was the effects of extended release naltrexone on the brain response to drug-related stimuli in patients with opioid use disorder. Those were the authors that were listed. Okay, now.
Kaustav. Dr. Kaustav.
So this is the article. This is the article that was selected. Okay. Now, before what you guys do, you just start with the introduction of the article and just try and summarize whatever the findings are, whatever has been written. So no, you have to make the audience understand what are the things that has been that has been given in the, this is the article where fMRI has been used. So you need to get a basic concept of fMRI. So at the outset, I have given an outline of an fMRI. So what is ML is a measure of method of physiological assessment of metabolism, hemodynamics, right? So it's functional assessment. Slides are not coming. Oh, कैसे करूं उसको? मतलब स्लाइड शो हो भी रहा है उसमें तो एक बार देखो नेक्स्ट वीडियो नेक्स्ट वीडियो right. So an outline about this fMRI. So instead of creating images of organs and tissues like what we do in MRI, it actually looks at the blood flow. It looks at the blood flow in the brain to detect areas of activity. Now, how does it look? How does it go about looking at it? It depends on the oxygen level actually. So this bold signal, blood oxygen level dependent signal. Okay. So the areas of activity where more blood flow will be there. Obviously, oxygenated hemoglobin will go more. Okay. So those things they map whether the oxygen is more in that blood or less in that blood. In that way, they know about the activity going on in that part of the brain. Okay. This is a very basic outline of how an fMRI works. Just because this article is represented or maybe it has a fMRI in its methodology. That's why just a brief outline of it. Now, as we measure picture in pixels, this is measured in voxels. Okay, it represents thousands of neurons. This unit of measurement, voxels. Okay, so the area of activity is often mapped by squares called voxels. Right. Now, the deoxygenated hemoglobin is affected differently by the magnetic field than oxygenated hemoglobin. This is the basic fact of how the fMRI works. So real-time task, resting state imaging, widespread applicability. Fine, all these things are just to make you aware of the fMRI. A typical research fMRI scanner has a strength of 3 Tesla, force about like 50,000 times stronger than the Earth's magnetic field. Right? Obviously, we know that when you go to the MRI lab, now even in MRI, you typically know and the watches get attached and all these things, right? So because this article is around addiction, a brief mention about what is the, see, I have not started the article as of yet. To give a brief outline. The neurobiology of addiction. Now, generally, you have 4 dopamine pathways, right? One is mesocortical, one is mesolimbic, one is tuberohypophyseal pathway, and the other one nigrostriatal, right? So mesocortical and mesolimbic are the most implicated in this addiction neurobiology. So in mesocortical, what does it do? We'll consider more on the mesocortical part because this article deals with that. Now the mesocortical part, what does it do? It's basically this ventral stratum is actually regulated from the cortex by the mesocortical path. It's actually the cortex having its inhibitory influence on this area, right? So this is where the crux of addiction will go in. Okay, this mesocortical pathway. Now, so as you can see here, this amygdala nucleus. What is ventral stratum, by the way? It's basically nucleus accumbens and olfactory nucleus. Yeah, those two comprise the ventral stratum. Now this ventral, what is the basic thing in a addicted brain? It's basically this the inhibitory influence of the prefrontal cortex is taken apart. Okay, and the augmentation of this reward and reward stimulus reward learning, this condition reward, the augmented response from these things are enhanced, right? So inhibition is down, augmentation is up, both lead to surge of this dopamine in this pathway. Amygdala, nucleus, all are involved in this, and this impulsivity compulsivity model will not go into that details. This model also helps in that. Okay, so basically the top down inhibition of by the frontal cortex or prefrontal cortex is taken apart. That is the main thing in chronic use of substances. There's a thing that occurs. Okay, right. So again, almost the similar cycle is shown here. There is this craving or drug expectation, and leading to a loss of control, takes the drug in much more amount, and then the withdrawal happens, and then again leading to expectation for the drug, and drug reinforces it. So an impaired, what we call is ERISA. ERISA is basically impaired response inhibition and salience attribution. So the attribution of a salient substance, salience, attribution of salience is impaired in here. The addicted brain attributes the salience to the drug more often than the other things, right? So salience attribution is impaired, response inhibition is impaired. This is a very widespread use construct, ERISA, which is used in very many models of addiction development, right? So again, we can see here that the reward circuits of ventral tegmental area, nucleus accumbens are up, and the top-down control you can see in this area, in the bottom part of it, this goes down. Top-down control goes down, right? Again, similar thing. The control of the brain in the addicted brain, reward drive and memory are going along, but the control that is lost in the addicted brain. Non-addicted brain, you can see all are interconnected, but the actual control by the prefrontal cortex is going down, right? The output is mostly based on this reward drive and memory, right? Okay. Now we'll come to a bit of naltrexone. We have still not started it. So the naltrexone is a mu opioid agonist. You know, opioids block GABA interneurons over ventral tegmental area dopamine and stimulates dopamine neuron in nucleus accumbens. So both resulting in an increased drug reinforcement effect, the blocking of GABA and stimulating of dopamine, right? Elimination half-life is given. Elimination half-life of naltrexone by injection is 5 to 10 days. Oral naltrexone 13 hours. Injection is 5 to 10 days. And this injection that has been used here is 380 mg every 4 weeks. That is the dose that has been used here in this article. Now we go to the introduction. I won't be reading through all of this because this is all what you get in the article. That all what you guys do actually. Don't go to the introduction straight away. Explain about what are the techniques that has been used. Now I have given a brief outline of MRI, brief outline of the neurobiology of brain, so that we can understand why they have taken the regions of interest as, what are the regions of interest that has been taken? Nucleus accumbens and middle orbitofrontal cortex, MOFC and NSC. Those are the two areas that has been taken in this article as the regions of interest, ROIs. Okay, so they have just given an introduction. They have made a case for why extended release naltrexone injection is should be given over an oral naltrexone, right? Now the hypothesis that has been mentioned in the article is XNRTX, which is the extended release naltrexone, reduces the brain response to opioid related but not to sexual or aversive stimuli in patients with opioid use disorder, and that this effect is associated with the concurrent changes in the severity of withdrawal symptoms. So what they have hypothesized is naltrexone reduces brain response to opioid drug related stimulus cues, but not to other pleasurable cues such as sexual or pleasurable or non-pleasurable sexual or aversive in patients with OUD, and that this effect of reduction of cues, reduction of opioid related brain response is also concurrent with the severity of withdrawal symptoms. That is what they have hypothesized. Okay, aim is to test the differential effect of XNRTX on the MCL, means mesocortical response, on XNRTX on the mesocortical response to opioid versus non-opioid evocative visual stimuli in detoxified individuals with OUD. Okay, they have mentioned that detoxified individuals will see the differential effect of opioid related stimuli versus non-opioid related stimuli with this XNRTX. Okay. Methodology, they have recruited through newspaper advertisements between 2012 and 14 with guaranteed benefits and compensations. Very seems very huge, but they have actually given nothing much. They have not. They've just compensated for the travel and all. Okay, you can find the supplementary materials also, or and in the main article. Written informed consent was taken and protocol was approved. Okay. So inclusion and exclusion criteria, they have gone to DSM-4 here because it has been done before 2013 actually. So opioid dependence has been taken and structured clinical interview with addiction severity index, 5th edition was taken. Age, and you can see the inclusion criteria. So all evidence of detoxification is one thing that you have to see here. Detoxification has been done, then only negative naloxone challenge test has been done, then only the patients has been taken, right? Exclusion criteria, huge lot of exclusion criteria has been mentioned. Of those, most of mention is basically they have ruled out other physical disorders. They have ruled out head trauma, pregnancy, breastfeeding, anything which can interfere in fMRI response, and current psychotic state or maybe any brain state that will lead to difficulty in interview or something like that, right? So yeah, these are the main exclusion criteria that have been mentioned. Now we'll all go to the PICO model. So this has to be there in your presentation. Population, intervention, control, and output. You have to present it that way. So population, 24 participants were taken. Intervention is the injection. Controls, no controls were used. And output is basically our outcome. Basically is the change in brain response to opioid-related sexual and aversive stimuli and severity of withdrawal symptoms, right? Now, how the fMRI task was done. So it is not presented in this way in the article, as you guys have gone through. It is very written, but you have to present it in this way so that the people can understand. So 4 categories of visual stimuli were cues were taken in pseudo-random order. They have mentioned pseudo, not a random order, but a pseudo-random order. Okay. Now each stimulus category consists of 24 unique images presented twice. That will amount to 24 into 8, 192 trials or images. Okay. Drug cues were given, which were basically 2 types: heroin related and prescription opioid related. You know the difference of heroin and prescription opioid related. How were the neutral stimuli taken? They were taken from the collection of non-drug images that is previously used in studies in cue reactivity. From other studies, they have taken whatever neutral cues, neutral stimuli they have given. The other MRI studies, they have taken there. Sexual stimuli is basically they have taken this from the International Affective Picture System. They base their stimuli according to a scale of pleasantness. Okay, so how much those sexual erotic pictures that will fall in the top quartile of the pleasantness of both males and females, they have taken it to be the sexual stimulus cues, and those which will fall in the bottom quartile of the pleasantness, they have taken in the aversive stimuli cues, right? So the hedonic value of each stimulus was determined by an unrelated. This was also done so that that's actually a good article. They have done many things, but still there were some critical episodes. The hedonic value of each stimulus were determined by an unrelated group of patients, not this group of patients, but unrelated group of patients. The drug stimuli you can see around 3.75. Sexual stimuli was much higher in pleasantness, 7.3 to 7.7, and aversive stimuli were around 1. And neutral, actually, drug stimuli and neutral stimuli were actually given same rates of pleasantness by other opioid use patients, which was very strange to see, because the opioid use patients are giving same to the neutral and the drug use. This was an unrelated group of patients. Maybe you would have skipped this part while reading your article. This was done separately. Okay, this is still not the present main part of that. Now, each fMRI trial of fMRI cue reactivity was stimulus was displayed for 500 milliseconds, and then crosshair displayed for 1500 milliseconds. This crosshair? Crosshair is that banduk target that we see in the screen in games and all. That's the crosshair. The crosshair, that's a stop basically. Displayed for 1500 milliseconds. Stimulus trials were interspersed with 48 baseline periods. Total displayed for 2000 milliseconds. Now, what were the things that were? Now we come to the scores and this part. What were the assessments that were done? So before each fMRI task, cow score was taken, self-reported opioid craving scale was taken, and self-reported opioid withdrawal scores were taken. So cows is objective, opioid withdrawal self-report is subjective, and a self-reported opioid craving. This was done before and after every fMRI task. Okay, so pre and post fMRI task. Now, how the procedure was done? before the first dose of XNRTX injection, 3 days before it, the first fMRI session was taken. And the first fMRI session, pre and post. Scores done. Pre and post, these 3 scores were done. First XNRTX injection was given 3 days after the first fMRI session. 7 to 14 days after that injection, the second fMRI session was done. And 20 to 64 days after that second fMRI session, the third fMRI session was done, which was named as optional. Now, you are getting that there are 2 types of scores being taken, pre and post fMRI. Now, there is another pre and post in this. Pre-treatment, on-treatment, post-treatment. So, fMRI, according to fMRI, there are pre and post scores. And according to the session of injection, there is pre-treatment, on-treatment, and post-treatment. Now, they had first offered, if you remember, they had offered a monthly injection of XNRTX. But we see here that there is only one XNRTX injection that was given. Okay. After that, there was a huge dropout. They had tried pre and post they would take, pre-injection, post-injection. But they have mentioned this, they could not get the post part. There was such a dropout, they termed as pre versus on. Pre-treatment and on-treatment. But that is what they could get basically. Okay. So pre-treatment fMRI was also done, post-treatment fMRI was done. And between this fMRI, these 3 scores were taken also. Pre-fMRI and post-fMRI. And the third fMRI was done, but it was optional because only 9 people actually followed up. Now, how would analyze the behavioral data or the 3 scores that we would analyze were the cow score, the self-reported craving, and the self-reported withdrawal. This was pre and post fMRI, right? And also pre and post treatment, right? So pre and post fMRI will also analyze, and pre and post treatment will also analyze. What are the effect on these scores? These are verbal scores, right? These are written scores. Okay, this is still not true. This is still not correlated with the fMRI scores. fMRI scores are different. These are all written scores, right? I have to mention a brief thing about ANOVA also. Maybe we can skip this part. Even that has to be mentioned. The statistical analysis that you want to study in this article, that also has to be mentioned. So this is how you have to present the journal, right? Okay. Now, what about the MRI data? Now, this bilateral NAT and MOFC were chosen as the regions of interest. Now, for each region of interest, the contrast values. Now, this is the contrast values. Those were written scores, and these are the contrast values. So how much the brain is becoming active in the area. Okay. These were each of the stimuli during the pre and on treatment are subjected to 2 into 3 repeated measures ANOVA. Difficult for you to understand at this point of time. Let it be. I'll just tell you the gist after that. Other brain regions were also analyzed, and significant activation was, P less than 0.05 threshold. Okay, I'll come where we basically have what they have done is that the MRI scores they have done in pre and on treatment. Okay, before the XNRTX, what was the level of blood going to that area, and after the XNRTX treatment, what is the level of blood going to that area? So the activation of those areas versus pre the injection and post the injection. This was the MRI part. That was the written score part. Okay. Another thing which they have done, I think is really very complex for you. Another thing which they have done is that they have actually, I have already told you that there is a score part, written score part, and there is this MRI contrast values part. What they have done in the end, they have correlated these two also. Whether the reduction in drug-related neural activity usually found by the MRI, reduction in drug-related neural activity, and the reduction in opioid craving due to this scores, whether they correlate or not. Even that has been found out at that. Okay, so various number of calculations they have done. Now the behavioral part, I already told you that if I go to this picture, it will be more clearer, right? I don't think you have found this picture in your. So where did I find it? Supplementary data. Always have to go to the supplementary information. It's a huge 6-page information. The article is 7 pages, supplementary is 6 pages. Okay, you have to go to the supplementary pages, right? It will be found in the main journal article. Okay, now you can see very easily here. They have this black one is the pre-fMRI score and post-fMRI is the gray one. These are scores of those three things: self-reported craving, self-reported withdrawal, and count. Okay. Now you see that pre-treatment, on-treatment, and post-treatment, the cow scores are almost similar in the pre and post fMRI, almost similar. They don't have significant differences. Here you can see every time they have a significant deviation, right? The self-reported craving part and the self-reported withdrawal, again, almost similar. Okay. So what they have told is that, now if I go to the previous slide, okay, fMRI Q-reactivity task increased self-reported craving but had no main effect on cow scores and self-reported withdrawal. Now you can correlate this. Key fMRI task, this is the pre and post fMRI, right? It had significant effect, or the post fMRI scores were elevated. See, this was only in the self-reported craving. So by seeing the drug-related images, their craving, self-reported craving was increased in every session. In every session they were increased. But in the cow scores and self-reported withdrawal, there was no such thing. Okay, this is one part of the results. Now let's go to the second part. Second part is all the scores have significantly decreased from the pre to the on-treatment part, right? All the scores. In totality, you can see that they have decreased, right? In totality, you can see that pre-treatment scores and on-treatment scores, they have decreased. Be it the pre or post fMRI, they have decreased significantly. So that has also been mentioned here. Cow score, self-reported craving, and withdrawal significantly declined from the pre-treatment to the on-treatment sessions. This is another part of the, okay. So all the three scores had declined from the original part to the in the pre-treatment to the on-treatment session. So that represents that XNRTX had an effect. Okay. So those scores were declining. Right. This is only one part of the study that is there. Okay. Now coming to the fMRI analysis. I will show you this graph, then I will show you. So if you come to the fMRI analysis, this is the pre-treatment and on-treatment. Move nahi kar raha hai. So pre-treatment is the black thing and on-treatment. Treatment means XNRTX wala. Pre-treatment is this, on-treatment is this. Now what they have told, see, in the NSCC part, only in this drug-related stimuli, they have found significant difference in the neural activity from the pre-treatment to the on-treatment part, but non-significant, NS they have told, non-significant differences in sexual and aversive stimuli. Again, in the MOFC part, they have found significant differences between these two, the drug-related stimuli, but they have not found so in the sexual and aversive stimuli. Okay, so it is going according to their hypothesis that XNRTX actually decreases the neural activity in the only to the drug-related cues, but not to the sexual and aversive cues. Right? That is going according to what they have hypothesized. That is all written here also. Okay. Now, here you can see that this is also from the supplementary condition, the supplementary pages. Okay, from the pre-treatment to the on-treatment part, the scores have decreased, as you can see from here also, that the scores have decreased from the pre-treatment to the on-treatment, right? In both, they have decreased considerably. But here also it has been shown the same, but they have increased in the post-treatment part. Okay, so that is what they have not researched enough in this part. So in the supplementary pages also, they told that they have not researched enough in this post-treatment area because they had huge dropouts. Okay, that is what I mentioned here. Now, if I go to pair-wise comparisons, okay, if you guys all can settle in, then only I'll start. See, I am not talking. You have to settle in, otherwise I'll not be settling there. Okay. Now, if I go to the pair-wise comparison, now there is something called a pair-wise comparison. How will it go? That the reduction in nucleus accumbens area, nucleus accumbens neural activity to drug stimuli did not significantly differ from that in sexual stimuli, but both were significantly greater than that to aversive stimuli. Okay. So drug was almost equivalent to the sexual part, but not to the aversive part. Now you'll get confused. अरे अभी तो हमने पढ़ा कि ड्रग का अच्छा खासा सिग्निफिकेंट रिडक्शन था, सेक्सुअल एवर्सिव का नहीं था. ये इसके साथ इसका डिफरेंस था, इसके साथ इसका डिफरेंस था. अब ये लोग क्या कर रहे हैं, ये जो डिफरेंस है ना, इसको कैलकुलेट कर रहे हैं इनके साथ, इन डिफरेंसेस के साथ. इन लोगों ने अभी तक इन दोनों का सिग्निफिकेंट डिफरेंस, इनका सिग्निफिकेंट डिफरेंस कैलकुलेट किया था कि ये दोनों सिग्निफिकेंटली डिफरेंट है. मतलब ये दोनों सिग्निफिकेंट डिफरेंट है कि नहीं, ये दोनों सिग्निफिकेंट है, ये दोनों नहीं है, ये दोनों सिग्निफिकेंट डिफरेंट है। अब ये लोग क्या बोल रहे हैं, ये जो डिफरेंस है ये तीनों ग्रुप्स में सिग्निफिकेंट है, मतलब तीनों ग्रुप्स में कैसा रिलेशन है उसका। तो ये बोल रहा है एनएससीसी में जो है वो ड्रग और सेक्सुअल का जो डिफरेंस है, ये जो दो डिफरेंस दिख रहे हैं, ये वाला और ये वाला डिफरेंस, ये डिफरेंस सिमिलर है देन द एवर्सिव वाला पार्ट व्हिच इज सीन हियर। द एवर्सिव वाला पार्ट डिफरेंस इज एक्चुअली बीइंग रिवर्स्ड। ओके, सो ये जो डिफरेंस है, डिफरेंस ये वाला पार्ट डिफरेंस माइनस माइनस, ठीक है, ये जो डिफरेंस है ये इन दोनों में इक्वल, ऑलमोस्ट इक्वल है, लेकिन एवर्सिव वाला काफी कम है इससे। उल्टा ऑन द एमओएफसी पार्ट व्हाट दे हैव सेड दैट ये वाला डिफरेंस इज मच मोर हायर देन बोथ दिस। सी है, ये देखो, ये छोटा डिफरेंस, ये भी छोटा डिफरेंस, ये डिफरेंसेस को फिर इन्होंने पेयर वाइज कंपेयर किया। ठीक है, ये थोड़ा सा मुश्किल हो सकता है लेकिन है, मतलब ऐसा किया है। पहले तो इन्होंने डिफरेंसेस ये किया है कि इसके साथ इसका डिफरेंस प्री वर्सेस ऑन ट्रीटमेंट है कि नहीं, तो ये बोला ये वाला सिग्निफिकेंट है, ये वाला नहीं है, ये वाला नहीं है, ये वाला है, ये वाला नहीं है, ये वाला नहीं है, यानी कि ड्रग रिलेटेड स्टिमुलाई प्री एंड ऑन ट्रीटमेंट का सिग्निफिकेंट डिफरेंसेस है। बट अब हम अगर ड्रग और सेक्सुअल और एवर्सिव को कंपेयर करें तो ये जो रिडक्शन है, ये जो माइनस दिस मतलब इतना बड़ा खंबा, ये बड़ा खंबा, ये दोनों इक्वल है ऑलमोस्ट, और ये उतना नहीं है, ये कम है। तो यानी कि ड्रग और सेक्सुअल का जो रिडक्शन है वो ऑलमोस्ट इक्वल है एनएसीसी, लेकिन एमओएफसी में क्या है, ड्रग का रिडक्शन सिग्निफिकेंट है, ये जो खंबा है बड़ा सिग्निफिकेंट है, लेकिन देखो ये दोनों खंबे छोटे छोटे हैं, मतलब जो डिफरेंस है वो छोटे छोटे हैं। ठीक है, तो वो उतना सिग्निफिकेंट नहीं है। ठीक है, तो ये वाला पेयर वाइज कंपैरिजन भी उन्होंने किया है। Again, the whole brain analysis was done to find out any other areas. They have mentioned those in the supplementary condition, supplementary table or pages. Don't need to go into that now. And the last also, what I told you they have done is that they have correlated this fMRI wala contrast values with the reduction in the fMRI contrast values from the pre-treatment to on-treatment with the scores that they have, objective scores that they have taken. Now they have found that in the NACC, what was there, significant correlation was found between reduction in drug-related neural activity between pre and on-treatment sessions in the NACC and the reduction in cow score. So the pre and on-treatment जो neural activity कम हुआ था, इंजेक्शन देने के बाद प्री ट्रीटमेंट से जो ऑन ट्रीटमेंट तक न्यूरल एक्टिविटी कम हुआ था, वो हम कोरिलेट कर सकते हैं रिडक्शन इन काउ स्कोर के साथ, उन्हीं के काउ स्कोर के साथ, यानी कि ऑब्जेक्टिव विड्रॉल के साथ हम उसको कोरिलेट कर सकते हैं सिर्फ एनएसीसी न्यूक्लियस अकम्पलेंस में। ऑन द अदर हैंड एमओएफसी में हम क्या कर सकते हैं, सेल्फ रिपोर्टेड विड्रॉल सिम्टम जो सीवियरिटी था काउज ने सेल्फ रिपोर्टेड, वो हम कोरिलेट कर सकते हैं एमओएफसी के ये प्री एंड ऑन ट्रीटमेंट जो रिडक्शन हुआ था। ठीक है, तो ये बोल रहा है एमओएफसी ज्यादा सेल्फ रिपोर्टेड वाले, मतलब सब्जेक्टिव उसमें आता है, एमओएफसी का कोरिलेशन सब्जेक्टिव से ज्यादा है और न्यूक्लियस अकम्पलेंस का कोरिलेशन ऑब्जेक्टिव से ज्यादा है। ये वो बोलना चाहते हैं लास्ट वाला कोरिलेशन करके, सेल्फ रिपोर्टेड क्रेविंग के साथ कुछ आया नहीं रिलेशन। ठीक है, वो लास्ट में लिखा। अच्छा, डिस्कशन में उन्होंने वही सब दोहराया है, छोड़ दो डिस्कशन, रिजल्ट समझो पहले। ठीक है, डिस्कशन में वही सब चीजें उन्होंने करने की कोशिश की है कि और स्टडीज में कितना वैसा किया है। जैसे दूसरे स्टडीज में कुछ है कि मिथाडोन रिड्यूस द mesocortical neural response to opioid cues in the amygdala and insula but not in the NSS and MOFC. So this is going against this article. Okay, so those things they have observed. They have also tried to give explanations कि हमारा जो correlation craving के साथ लास्ट में था, craving self craving के साथ किसी का correlation नहीं आया, तो उसका इन्होंने explanation देने की कोशिश की। craving is much more difficult to report and craving has a closer association with other ROIs, other brain regions which are not studied. That is the correlation explanation they have tried to give. Another explanation they have tried to give of effect of opioid antagonism on neural behavioral response normally remains mixed because we have not found very like यहाँ पे जो बोल रहे हैं कि ड्रग रिलेटेड क्यूज के साथ ही ज्यादा कोरिलेशन है, सेक्सुअल एवर्सिव के साथ नहीं है, वो लिटरेचर में मिक्स्ड जैसे रिस्पॉन्सेस है। बहुत टाइम इन्होंने इंट्रोडक्शन में भी कहा है कि इंजेक्शन नैल्ट्रेक्सोन देने से जो फूड का पैलेटेबल सब्सटेंस का जो हेडोनिक वैल्यू है वो भी कम हो जाता है कभी कभी। ठीक है ना, तो इसीलिए वो भी मिक्स्ड रिजल्ट है, उसका कुछ एक्सप्लेनेशन दिया है उन्होंने। उन्होंने क्या लिमिटेशन दिया है, स्मॉल साइज उन्होंने मेंशन किया है, नो प्लेसिबो कंट्रोल ये भी मेंशन किया है, उसका भी एक्सप्लेनेशन दिया है क्यों प्लेसिबो नहीं लिया था। उन्होंने बोला कि पार्टिसिपेंट्स में क्विकली फाइंड आउट व्हिच ग्रुप दे आर इन आफ्टर एक्सपीरियंसिंग द फर्स्ट डोज ऑफ एनाल्जेसिक्स। सो उन्होंने एक्सप्लेनेशन दिया है एंड रिस्क ऑफ ओपियोइड ओवरडोज, दैट इज द एक्सप्लेनेशन दे हैव। Stimuli provided were matched on pleasantness scale, but अदर hedonic values pleasantness के अलावा भी और भी hedonic values है, उस पे मैच नहीं किया हुआ. Limited number of brain region of interest, 2 ही region of interest दिए थे इन्होंने, and relatively small sample size. That is the thing they have. Conclusion what they have concluded is extended release naltrexone reduces the nucleus accumbens and MOFC response to opioid related visual stimuli in detoxification patients with OUD. उनका first finding था जो मैंने जो फिगर में दिखाया कि सेक्सुअल और एवर्सिव के मुकाबले इनका सिग्निफिकेंट था. ठीक है. इफेक्ट इज स्पेसिफिक टू ओपियोइड रिलेटेड स्टिमुलाई इन द एमओएफसी बट नॉट इन द एनएससी. वो लास्ट जो डिफरेंस दिखाया कि डिफरेंस का कोरिलेशन उतना नहीं बना, वो एमओएफसी में बना था लेकिन एनएससी में नहीं बना. ठीक है. And reduction in the mesocortical response to opioid related cues is associated with the reduction in opioid withdrawal. जो लास्ट में उन्होंने कोरिलेशन किया था कि विड्रॉल के साथ ये opioid related cues का एसोसिएशन है बट क्रेविंग के साथ नहीं है, क्योंकि विड्रॉल का सब्जेक्टिव और ऑब्जेक्टिव के साथ आई थिंक ऑब्जेक्टिव का एनएससी में था, सब्जेक्टिव का इसमें था, क्या नाम है, एमओएफसी में था, लेकिन क्रेविंग के साथ कोरिलेशन नहीं बना. ये भी लास्ट में उन्होंने कंक्लूड किया. अब मेरा प्रेजेंटर्स कमेंट्स क्या था. टाइटल ऑफ द स्टडी बहुत अच्छा है, कंपैरिजन मेंशन ही नहीं किया टाइटल ऑफ द स्टडी. ये मेरा फर्स्ट पॉइंट, ये ऐसा मेरा फर्स्ट ईयर जेआर मेरा मुझे जो दिमाग में आया मैंने लिखा था. तुम दो तरीके से कर सकते हो. क्या कर सकते हो कि तुमने इंट्रोडक्शन पढ़ लिया, इंट्रोडक्शन के बाद अपना कमेंट दे सकते हो, फिर हाँ ऐसे स्टेप बाय स्टेप भी कर सकते हो और लास्ट में अपना करके दे सकते हो. टाइटल ऑफ द स्टडी में कंप्लीटली वो नहीं था. एब्स्ट्रैक्ट वाज वेल रिप्रेजेंटेटिव ऑफ द होल स्टडी. आई प्रेज द एब्स्ट्रैक्ट. Introduction, they have told that oral naltrexone has poor compliance, okay, and that's why injection naltrexone needs to be given. But they have also mentioned in the reference that BNT is behavioral naltrexone therapy. It is a concurrent naltrexone therapy that is to be given with oral naltrexone. So why did not they try BNT before trying out this injection therapy? They had BNT had good responses with the oral, so why did not they try that? Maybe some motive going on. Background systematically shows why comparison between effects and NTX and naltrexone is the purpose. Fine. Inclusion exclusion में only few regular medications were excluded. Although they had excluded a huge lot of physical disorders, but medications they had not excluded much. The glaring thing was that they did not exclude much of the substances. How come? Exclusion of other substances are very ambiguous. Very ambiguous. Only few psychiatric disorders were mentioned to be excluded. Fine. Methodology, specific number of images chosen, could not find the explanation. Again, I could not find the explanation in the supplementary data. Maybe in the IAPC International Affective Picture System, maybe there is some methodology, but still they have not mentioned it. Interval in which the fMRIs were done also not explained, not substantiated. Lack of completion of all the procedures of every participant has affected the results. Fine. One of the authors had received consulting fees from Alkermes PLC, and D. Langeman, this guy, received 2 honoraria from the same company, which donated the medications. So there is this conflict of interest which is coming clearly. Okay, it was mentioned in the article also. Conclusively, the clinical utility of MCL-Q reactivity in monitoring the XNR NTX treatment outcomes, thus using it as clinical biomarker, still needs a lot of research. According to me, at that point, this was my comment. However, I will tell you what I got afterwards. After discussion of we had this discussion. It's a very great thing that came out. They have tried to correlate with the withdrawal scores. Every time now and then they have tried to correlate withdrawal scores. In the first only they have mentioned the patients have been detoxified and they have a negative naltrexone challenges. And what was their you could see the article, what was their average cow scores? 2.3. This is a subclinical variety of cow scores. Less than 5 is subclinical. Obviously they will have subclinical. And now they are doing it with a subclinical variety of scores and they are telling that there is this opioid withdrawal correlation and all these things. Totally farce. How can I get a withdrawal score, correlation when I don't have withdrawal? They are totally detoxified. This was a thing that was glaring in this year. We wrote a letter to the editor. We had written a 3-page letter, a 2-page letter. They have given us a 3-page reply back. They have replied huge lot of things. So I'll show you the mail. Maybe we were also confused after that. But they did not publish a letter to the editor. This okay. I'm still not remembering what, but I have it in my mail. Okay. Ma'am, partly satisfactory. They have told that we have done this, but it was not mentioned in the main step. Basically, it was a gist. Okay. And although we did not tell that the authors received a consulting fees, they already mentioned, so we did not tell it. Okay. Now, this things has to be taken with a pinch of salt, because you are every time you are going it with a withdrawal है कहाँ? इधर डिटॉक्सिफाइड पेशेंट लेके तुम कर रहे हो, विड्रॉल कहाँ है? ठीक है. और एक चीज जो बाद में आया कि ओरल बुप्रोपिन और नैलोक्सोन कॉम्बिनेशन का जो इतना अच्छा हम लोग का मिलता है रिस्पॉन्स, वो चीज के साथ तुमने कंपेयर ही नहीं किया. ऑल्दो ठीक है, ये एक एंटागनिस्ट थेरेपी है, वो एक एगनिस्ट थेरेपी है, बट स्टिल यू कुड हैव studied it with the yeah, as a comparison, right? So those are things which are missing. That they have done it very meticulously. I am not questioning that. That's what. Everything they will do so meticulously. Oh, great paper. Then something you'll find that there is this. Okay. Now, for you guys to understand is that this methodology part, they have done with so many sports. See, here sports. It took me around 1.5 months to understand this. And after the journal club also, I was trying on understanding. Again, 1 month I took for writing the electro editor, obviously the help of my SRs. So the gist for you is that before beginning a journal club, you have to summarize a few things about the specialties of that article. Maybe they are like one article Ishani presented on, I think, face related, some emotional deficits and all things. So you could have mentioned, she could have mentioned 2 or 3 slides regarding that. What is the gist of that? Then only the audience can understand. So why they have taken these 2 areas? Because the addiction psychiatry is going around through those neurobiology. Okay, so that I have mentioned, right? fMRI, what is it? Basic things, right? So these things you have to go about. Now it will take time, and you guys need to 7 days before you give the article to everyone, and you guys start preparing 1 month to prepare it. Otherwise, this is how you will criticize or maybe find out journals, read journals with a critical brain. Okay, not कि अच्छे लिखा है तो सही होगा, ऐसा भी नहीं, थोड़ा सा करना पड़ेगा. It is a bit complex. I don't know how much justice I have done in, so I was just hurrying up. It needs more time than I could have mentioned. What is the time? 9:50. I think anyone wants to, you can.
Anybody any questions?
कैसे पूछे यहाँ से? Sir, if any of the audience or in the other screens, if they have a question, sir, please you can chip in or comments.
Yeah. Hello, Kaustav. Can you hear me? Hello.
मुझे दिख नहीं रहा है.
Can you hear me? Hello. Hello.
Hello, sir.
Yes. So my comment is nice presentation, by the way. You covered all the things. This is about the use of cow score. So
Yes, sir.
I think the article is to mention the cues response that you get in the, you can say, abstinent state. One of the reasons for say relapse is that withdrawal symptoms, they keep cropping up. We know that even after detoxification, when the patient is like not having major withdrawal symptoms, the reason for relapse is that intermittently there are these withdrawal symptoms that crop up that can be a cause of relapse. So and mostly these cues, they can trigger these withdrawal symptoms. So they have tried to do this. They have given a cue, and after the cue, they have measured whether there were any withdrawal symptoms and whether the medication is, significantly reducing those withdrawal symptoms that occur after a cue. So I think for that, but yes, that is the point. Whether cows is a good scale to measure that specific, withdrawal symptoms, because those you don't see severe withdrawal symptoms in that area, but craving, etc., can be there. So that is one thing I think why they have used those scales. Like even during the abstinent phase, it is not like when there is abstinence, the withdrawal symptoms completely say go away. They can arise for some period of time, they may be short lasting, but specifically after Qs they can come. So I think the study is specifically marked for those symptoms, and that is why I think that's what I understood. That is why we use those the T score. So that's all.
Sir, I think excellent observation. But the thing is that if I'm muted or not.
No, I can hear you.
Acha, right. So, sir, the thing is, they could have, withdrawal symptoms. They're mostly after detoxification, sir. As far as I know, it is mostly psychological withdrawal symptoms that might be propping up here and there. Physical withdrawal symptoms will be very hard to get. And the thing is that a difference of a single point, statistical significance, they are commenting because they had an average score over 2.4 or 2.5, and they decreased to 1.5 or 1.6. So, a decrease of 1 point leading to statistical significance because the baseline was low, but clinical significance will be far off from the statistical significance. So that was our point, ki whether statistical significance can always be marked as a parallel of clinical significance. So
Yes, but
that is one thing.
That again, you calculate the sample size based upon the effect that you want. Okay. So whether that is another exercise that we can carry out, that whether keeping what amount of change will be significant, and for that, what will be the population, like what will be the number of patients where we can confidently say. So you calculate the sample size based on that, how much effect
sir,
size.
understood.
Yes.
But the thing is, sir, if you go to the scores, actually, you will see that the scores were something like the mean and standard deviation is something around 2.5 plus minus 2.3. So the standard deviation, twice the standard deviation was much greater than the mean. So it's in such
variability
samples,
is a lot of
yes,
variability.
Sir. Exactly, sir. So it's those are the things
yes,
which
yes, again, see. So the main thing is that if you have a comparison group, then you think that these things will eliminate itself. But yes, that is right, because many studies we find that the statistical significance that we see, whether that correlates into clinical significance, whether it does, that is true. But how do we go about doing the research? If we were to able to do it in a better way. So it's an attempt, I think, to in that area. That is there. But yeah, definitely, if we have a larger population and we do the same study, if we get even a small change in a large study is, you can say, significant, because that mostly in the RCTs also, even if we are studying therapeutic drugs, you see many times we see on HAM-D or other things, we see a difference of 1 or 2 points. But because they have studied thousands of patients, large population, so you can say that it becomes significant. Here the population also is new. That is also one of the drawbacks. Like 24 subjects we've taken. That's also there.
Right, sir. Accepted, sir. Thank you, sir.
Thank you.
Thank you, sir. Thank you.